Hello, my name is Tejas Patil. I'm a thoracic oncologist at the University of Colorado Cancer Center, and I focus on taking care of patients who have lung cancer and who are receiving targeted therapies. Most patients with lung cancer will receive either some combination of chemotherapy, immunotherapy, or targeted therapy. Targeted therapies are really meant for patients whose lung cancer have very specific mutations that we can treat with oral pills, often called tyrosine kinase inhibitors. One of the mutations that we see in lung cancer is what's called a RET gene rearrangement or a RET fusion. And currently, the two FDA-approved treatments for patients with RET rearranged lung cancer include a drug called selpercatinib and another drug called pralsetinib. And while these drugs are really effective, and most patients who are on these treatments really experience some degree of normalcy with some chronic side effects that are related to the drug, one of the challenges we face as a lung cancer community is that most patients will develop most patients' cancers will develop some form of resistance to either selpercatinib or pralsetinib. Some of the new treatments that are on the horizon are second generation RET tyrosine kinase inhibitors or pills that are designed to treat some common resistance mutations that we see in RET cancers. Some of the agents are a compound called TAS-0953, or another one called EP0031. There are also trials that look at combining the selpercatinib or the pralsetinib with something new. And this can be an IV treatment. So there is an ongoing clinical trial that uses a compound called amivantamab in combination with patients' selpercatinib or pralsetinib. And this type of study is really designed to hit what's called off-target resistance. That is when the cancer starts to use other growth signals outside of the RET gene to grow. And finally, there are trials that are looking at novel immune therapy treatments in patients with RET rearranged cancers. And I think this last category is going to become very important in the coming 5 to 10 years. We know that patients who have RET rearranged cancers generally don't respond to standard immunotherapies with drugs like Keytruda or Opdivo. And so the question is, how do we make RET cancers more sensitive to treatments that are either already available or treatments that are in development?